Hey you guys, welcome back for another week of topics and tips. As promised, we're getting into hypertension this week. So let's discuss all things hypertension. We'll be going over the ACC and AHA guidelines. And yes, since 2019, the FMP and AGMP exams are testing on the ACC and AHA guidelines. We'll also go over a few of the common medications, those thiazides, those ACEs, those ARBs, those calcium channel blockers, just to give you that foundation knowledge. And I like to give you all the little tidbits so as you're studying and building and preparing for boards and practice, that you can be successful and hopefully tie all this knowledge together and make it a little bit easier, eliminating all the fluff and getting straight to the nitty gritty, right? All right, you guys, let's get into it. So, for those of you guys who have been following me, seen my videos, taking my courses, welcome back and thank you guys for all of your support. But for those of you guys who are new to me, hey y'all, I'm Dr. Brittany Weinstock. I'm a family nurse practitioner and I'm the founder and CEO of the Nursing Studio. I created this in hopes of helping another nurse or nurse practitioner so that y'all can be successful on your exams, in school, on this nursing journey, on your boards, as well as in practice. So I always like to give the disclaimer that my videos are designed to help you have study and practice a little bit easier, so that you're able to apply this and be successful on boards and in practice, but not utilizing these videos for treatment purposes and end all be all, because we treat on a patient by patient basis. So with that being said, let's get into the content. All right. So you hear me talking about the ACC and AHA guidelines, and it has varied some from the previous JNC8. We still follow the same treatments as far as those thiazides, those calcium channel blockers, those ACEs, those ARBs, and how we treat with those. But the criteria of initiating treatment is where things have changed with these guidelines. And personally, for me, I like these, but let me explain it a little bit for you guys, okay? So we have always known that our golden number is that 120 over 80. I don't care how things fluctuate. That's that number that we have always had as a marker. And with this, it still is in play. So if it is greater than 120 over 80, I tell everybody to think of this as the pre-hypertension phase, okay? So when we think about pre-hypertension, just as we do with anything that is pre in those beginning stages, pre-diabetes, any of those things, we want to start to incorporate lifestyle modifications, right? So when your patient, no matter their age, no matter their health history, if they're starting to exceed the blood pressure consistently of 120 over 80, we want to start incorporating those lifestyle modifications, okay? So, if the patient presents to you like that, if you see the scenario on an exam, you want to start to think of those things and what are those lifestyle modifications? Incorporating that DASH diet where you're having low sodium in their meals, right? Having them to exercise at least 5 days a week for 30 minutes of each of those days. It doesn't have to be 30 minutes altogether, but that is the consensus for the guidelines, right? And continue to follow these things. Now, the next parameter we bump up, that next goal range is 130 over 90. Okay, so now, if your patient has comorbidities, meaning they have other issues, health in their health history, like diabetes, kidney disease, high cholesterol, things of that nature. So, if they have other comorbidities, you do not want their blood pressure to exceed 130 over 90. Again, we really don't want it above that 120 to 80 range, but we know that patients with hypertension, it is going to be higher, right? But if they have additional comorbidities, we need to keep this thing under control because it increases their risk factor for heart disease and other complications when the hypertension is greater. So 130 over 90, if you see this in your patients and they have other comorbidities, you go ahead and initiate therapy then. You remember before we were looking at, okay, what's their age? What comorbidities do they have? Have they had this amount of times? No. They have the comorbidities. They're having the blood pressure of 130 over 90 exceeding over that goal range for this population, initiate therapy. Initiate that treatment. Okay. So that's where we start to incorporate those medicines. All right. You will continue the lifestyle modifications, but now is the time that we are putting medications into play. And I'll get into what those treatment options are and how to utilize those. But right now, I just want to give you this foundational knowledge to know when to start treatment. Okay. And then lastly, the third stage is that 140 over 90 range. Now, this goal range is for our healthy population. It's with those patients that don't have any other comorbidities, health history. So if that healthy population comes in, no matter the age, no matter their demographic, anything like that, their race, anything, if it's greater than 140 and over 90 for this population, that's when you want to initiate medications at that time. Okay. So now that you have that foundational knowledge, let's get into the actual treatments. Now, again, when I told you about treatments and I said this still follows what the JNC 8 was talking about, this will make more sense when I explain and hear what I meant by that. Okay. Now, remembering with that criteria that we utilize with JNC 8, we identify versus uh, I would say non-black individuals as well as black patients in the category that those treatments go by, as well as knowing if they're diabetic or have a history of chronic kidney disease. With JNC8, that was the big foundational piece of how we um, identify treatment options. So with the non-black population and they're hypertensive, you want to, when if they are reaching that 130 over 90 or 140 over 90 category where you need to initiate medications, then you need to start to consider who falls in that population, right? So age no longer matters. We're looking at um non-black versus black patients, as well as, again, chronic kidney disease or diabetics, right? So, if they are hypertensive and non-black, they can be treated with any of the medications: the thiazides, the ACEs, the ARBs, or the calcium channel blockers. Those are the common foundation that we utilize, especially for boards, because I want y'all to know, blood pressure it varies so much. So when you're preparing for boards, I want you to think textbook, 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 okay? And so because they're testing you to see entry level, that you know how to identify this, the parameters that we are gauging and what guidelines we're following, and treating them accordingly and at the appropriate time. Now, in practice, again, things vary so much, but for our hypertensive non-black population of patients, whether they're meeting that criteria of the 130 over 90 range because they have comorbidities, or if they're a healthy population and it's that 140 over 90 range, again, they can have the thiazides, the ACEs, the ARBs, or calcium channel blockers. Remembering, for this textbook purposes, thiazides are the first line therapy, okay? And I'm going to get into these medications, contraindications, mechanism of actions in a second. I just want you to group this together because, as you can see, I'm building on it, right? So we are first identifying what are the ACC and AHA guidelines. So you got that, right? So we have our 120 over 80. If it's above, we start to initiate those lifestyle modification, right? All right. If they have comorbidities and they are exceeding the blood pressure of 130 over 90, we start to initiate medications. If they are healthy and they start to exceed the blood pressure of 140 over 90, we start to initiate the medications. So now I'm just simply explaining how you decide what you're going to initiate for the particular patient that is in front of you. So next, if they are hypertensive and they are black, you want to treat with a thiazide or a calcium channel blocker, because it is shown that black patients respond well to these medications. And you would also learn, like in practice, that you will see that thiazides and calcium channel blockers as combination medications actually work best for the black community. But for testing purposes, you want to treat with a thiazide or a calcium channel blocker but you want to start with the thiazide first. Now, there are variances where that you may need to utilize other medications. Again, for testing purposes, I need you to understand that entry level, the first thing you want to do are those two drug classes that are known to work for black populations better. They respond better to these drug classes. So that needs to be known, and these are the first ones that you go to. So you're looking for these first and second line therapies, and then we start to think deeper. Okay. Now, any patient with a history of chronic kidney disease or diabetes, no matter their race, you want to start and treat with those ACEs or ARBs. Why? Because these are working to give that kidney, it protects the kidney function, okay? We already are taking hits from the hypertension, from having a history of chronic kidney disease, from diabetes. All of this stuff affects the kidneys. So we need extra protection from the medication as well, ones that, you know, work to support and promote the functioning of those kidneys. So those are the best medications if those are the comorbidities that your patient has. All right. All right. So let's go a little bit deeper to dive into these drug classes that I am mentioning here. All right, thiazides. All right, they end in thiazides. I like to tell y'all the endings. So if you're seeing medications that you're not familiar with, that, maybe a new medicine listed on the exam, if it says thiazide on the ending, it's a thiazide, right? And so thiazides are diuretics. They're not as heavy, so to speak, as like your loop diuretics, um, but it does have a diuretic component. um, it works by that sodium reabsorption is decreased. So that's where that diuretic portion comes in, because we're starting to lose more water, which in turn helps with the decrease of the blood pressure, right? Um, Also, with this, I like to tell you guys to pay attention to the electrolytes, because yes, we do have decreased sodium reabsorption. Yes, there is some potassium loss. So watch these levels, because if somebody has hypokalemia, you're going to be very cautious with giving these sorts of medicines, right? Also, it thiazides can also cause calcium retention. It does cause you to retain calcium in the body. And sidebar, that's where you'll see these additional uses. That's why thiazides are sometimes utilized with osteoporosis. Um, Osteoporosis, osteopenia, I discussed last week. So if you need to delve into that a little bit more, check that video out. I'll put it in the description so we can go into that. But just a quick insert with osteoporosis, this is the more severe state where they have a weakened bone density. And so what happens is they're at risk for fractures, right? Well, with the retention of the calcium, it is said that thiazides help, they have a higher bone density. So it helps with lessening the fractures, is why thiazides can be utilized for this. But all that tied together, when I'm telling you, when you have a patient on thiazides, some things you want to make sure that you're looking out for. Yes, we know that it aids in um, reducing the blood pressure. It's also helpful for edema, because of that mild diuretic effect that it has. It is a diuretic. It's also that first line therapy that in most cases what we utilize for blood pressure management. But you gotta pay attention to the factors that you need to look at. So with that foundational knowledge of how it affects the sodium, the potassium loss, the calcium retention, you must watch those electrolytes, because people who are already at a deficit in these electrolytes or in excess, you need to watch out for these. So always pay attention to the electrolytes. This is also has a sulfur base, so you need to be cognizant of that, because you do not want to give this to patients who have a sulfur allergy. It is also said that thiazides can cause gout, so you don't want to give it to who? Patients with gout, right? Because it's going to just um, worsen their symptoms. And that's the basis of thiazides. Just take note of that, so that when you are reading the scenarios and processing through how to treat, think of all these factors, because yes, this is first line in most cases. And so for boards purposes, if they're looking for the initial treatment, you're typically going to go with this. But if they start to give you scenarios and these electrolytes are off, or the patient has a sulfur allergy or gout, You don't want to go with that, right? So I need you to be able to identify that for boards as well as practice. All righty. Next, we have our calcium channel blockers. Calcium channel blockers, they end in pine, but it's said like pine, like amlodipine, Pine are the endings. So when you see that, you should think about your calcium channel blockers. And they work just like their name states. They're blocking those calcium channels from entering into the cells of the heart, which allows those vessels to relax, which lessens that cardiac output, which allows for the blood pressure to be lower, right? To decrease that blood pressure. Now, you do not want to give calcium channel blockers to patients with heart failure or AV block. So be very cognizant that you are looking at their health history, asking them about their cardiac history before prescribing these calcium channel blockers. And also, tell your patients to avoid grapefruit while taking these medications because it does alter um, the absorption and the functioning of the medicine, okay? ACE inhibitors, very common medications, end in pril, PRIL. They work just as the name states by inhibiting that angiotensin converting enzyme. Same thing, it allows those vessels to relax and dilate, okay? So this is reducing that blood pressure, but with this, because of how the angiotensin converting enzyme works, it allows the kidneys and the heart to have to do less work, right? So this is why we push to give ACEs and ARBs to those patients who have chronic kidney disease or who may be diabetic because of the hit and effects that their kidneys already have. This medication protects it by reducing the workload on the kidneys as well as the heart, okay? Now, I do want you to watch out because one thing you should know when I talk about ACE inhibitors, you want to watch out for patients having a cough and angioedema, commonly in that African American population. Um, so they may have swollen lips. They may say that they're consistently having a cough since the initiation of the medication. If they tell you this, you need to stop and try another medication for this patient population. It can also cause dizziness. So again, these are your ACE inhibitors ending in pril, okay? And then lastly are our ARBs. Our ARBs, they end in sartan, Sartan, okay? Like almost sartan. Now, these work similarly to our ACE inhibitors because ARBs block that angiotensin 2 receptor, also allowing that kidneys to have less of a workload. So again, this is why we go for our ACEs or our ARBs for those patients with those comorbidities, but it does the same thing and allows for the blood pressure to reduce. Okay. Now, you guys, thank you for watching. I hope that you have found this helpful. I know hypertension can be heavy because there's so many moving parts, but I wanted to take a moment to break it down in a fashion so that you can see what the guidelines are for the ACC and AHA guidelines because sometimes that there's so many moving parts that we get overwhelmed. Sometimes we're questioning whether we're following this guideline or that guideline for boards and for practice. And so I like to update you on where we are with things, tell you the nitty gritty of what it is and why we're doing it, and then understanding the basics of those common medications so that you can make quick and sound judgment for your board success as well as success in practice for your patient's purposes. But I do all this to try to make it easier so you can tie things together because you have the knowledge, but sometimes you just need it broken down and concise so you can put the puzzle together. So hopefully it was helpful for you guys. Please let me know in the comments if you found it helpful, if you need me to elaborate more on something, if you found something that you are still having questions on and you want me to go back over, please put it there. I'm happy to do so. But as always, thank you. Please like, comment, and subscribe and share with a friend or colleague or whoever you may think may find this helpful. But be sure to meet me back here. Tomorrow we'll be doing our Work It Out Wednesday video to test your knowledge on this. So you will see scenarios where they're of different race, where they're having the different goal range for the ACC and AHA guidelines, where they may have chronic kidney disease or diabetes, and so that you are able to identify and test your knowledge on when and how to utilize these treatments and who the treatment is actually warranted for. So meet me back here tomorrow for that. And then on Thursday, for this month, I have been doing soap notes to kind of get your mind on that page to make sure you're understanding how to do a soap note as well as tying it together. So on Thursday, we'll be going through that on hypertension, on a hypertension scenario, so you can see it from that fashion as well. All right, you guys, thank you again. Meet me back here and subscribe. Bye, y'all.